Hi, I'm Richard. I'm a speech and language therapist and a lecturer based in the UK. In today's video, I'm going to provide a step-by-step guide how I critically appraised a cohort study using the JBI checklist for cohort studies. I'll be critically appraising trends in and predictors of swallowing and social eating outcomes in head and neck cancer survivors, a longitudinal analysis of Head and Neck 5000, which was written by Joanne Patterson et al. And published in Oral Oncology. In this study, the authors were interested in how people with certain kinds of head and neck cancer recovered and which factors predicted who would go on to have difficulties with swallowing, also known as dysphagia, and eating socially in the long term. I hope this video will be useful to students learning how to critically appraise literature, practicing clinicians, and members of the public interested to know how healthcare professionals evaluate different kinds of evidence. Let's start with a brief definition of what critical appraisal is. Critical appraisal is a systematic evaluation of research to assess its usefulness and validity to a given context. A critical appraisal checklist is a tool used to help readers with this evaluation process. Each checklist contains a set of questions designed to prompt the reader to look for certain information in the research. The number and kind of questions in a checklist depend upon the kind of study you are reading. The cohort checklist used today is published by JBI. This checklist asks 11 questions and asks the reader to rate each question yes, no, unclear, or not applicable. I will now go through each of these 11 questions in turn and attempt to answer them. The JBI appraisal checklist suggests that the study should have clear inclusion and exclusion criteria that are developed prior to recruitment of study participants. The two groups selected for comparison should be as similar as possible in all characteristics except for their exposure status. In the methods section on page 2 and the results section on page 3, the study describes including participants with oral cavity, oropharyngeal and laryngeal cancers treated with curative intent and not recorded as having recurred in the year post-recruitment. So for question 1 on the checklist, I would say not applicable. The checklist suggests that exposure measures should be clearly defined and described in detail. We learned from question 1 that the study did not have an unexposed group, so for question 2 on the checklist, I would say not applicable. The checklist suggests that the study should clearly describe the method of measurement of exposure. On page 2 in the methods section, the study described that clinical information was abstracted from the patient's medical records, including the International Classification of Diseases version 10 code for the patient's tumour site and the TNM staging following the American Head and Neck Society system. So for question 3 in the checklist, I would say yes, the exposure was measured in a valid and reliable way. The checklist suggests that confounding occurs when the estimated intervention exposure effect is biased by the presence of some difference between the comparison groups. This typically includes things like baseline characteristics, prognostic factors, and concomitant exposures. This influences the direction of the study results. A good study will identify potential confounders and measure them. In the methods section on page 2 to 3 and the results section on page 3, the authors identified a wide range of variables taken at baseline which could potentially impact head and neck cancer and their subsequent outcomes. This included demographic factors such as age, ethnicity and sex, socioeconomic factors such as level of education and level of deprivation based upon the participant's home postcode, lifestyle factors such as smoking status and alcohol consumption, etc. etc. So for question 4 on the checklist, I would say yes, confounding factors were identified. The checklist suggests that confounding factors may be dealt with within the study design, such as matching or stratifying sampling of participants, or in data analysis by using some form of multivariate regression analysis. In the methods section on page 2, the authors outline using mixed effects linear multivariate regression. This will be discussed in more detail for question 11, but for the purposes of this question, suffice to say that it is an appropriate strategy. So for question 5 on the checklist, I would say yes, strategies to deal with confounding factors were stated. The checklist suggests that the participants should be free of the outcomes of interest at the start of the study. In the methods section on page 2, the study describes recruiting participants who were diagnosed with a new primary head and neck cancer who had not begun curative treatment yet. The baseline measures reported in Table 2 on page 4 confirm that almost half had difficulty swallowing and half had trouble in social eating, with scores above 5, which were indicative of a need for supportive care. So for question 6 on the checklist, I would say no, the participants were not free of the outcome at the start of the study. However, like with question 1, this is not necessarily a problem and does not suggest that the methodology is flawed, as this is a prognostic cohort study where the researchers are more interested in tracking changes over time rather than the onset of new symptoms. The checklist suggests establishing the objectivity of the outcome measure, how the measurement was conducted, and whether the measurement tool was a validated instrument. In the methods section on page 2, the study described using the head and neck specific version of the European Organisation for Research and Treatment of Cancer Quality of Life questionnaire. The questionnaire includes 35 questions where participants rate agreement on a 4-point Likert type scale from 1, not at all, to 4, very much, where higher scores represent more severe symptoms experienced during the past week. In this study, the authors looked at the responses to items in the swallowing and social eating scales. This includes items 5, 6, 7 and 8 for swallowing, and items 19, 20, 21 and 22 for social eating. Examples of the kinds of questions asked include: have you had problems swallowing liquids, and have you had trouble eating in front of other people? The authors linearly transformed participants' responses for each subscale into a score in the range 0 to 100. So for question 7 on the checklist, I would say yes, the outcomes were measured in a valid and reliable way. The Quality of Life Questionnaire Head and Neck Cancer 35 is a formal questionnaire that has been standardised with hundreds of patients across multiple countries. A newer version including 43 questions has since been published and validated, but includes no substantive differences as far as the swallowing and social eating subscales are concerned. The checklist suggests that the appropriate length of time for follow-up will vary depending upon the nature and characteristics of the population of interest, the disease, the interventions used, etc. It suggests in cohort studies it is important that the follow-up is long enough to enable the outcomes. In the methods section on page 2, the study reports that participants completed baseline measures before treatment began and surveys at 4 and 12 months post-baseline. In the results section on pages 3 to 5, the authors reported a clear trajectory of symptoms where at 4 months scores were significantly worse than a baseline for swallowing and eating socially. At 12 months there was a reduction in the scores compared to 4 months, but the scores were still elevated compared to baseline. So for question 8 on the checklist, I would say yes, the follow-up time reported was sufficient for outcomes to occur. The checklist suggests it is important in the cohort studies for a greater percentage of people to be followed up. At least 80% of participants should be followed up. A dropout rate of 5% or less is considered insignificant. In the results section on page 4, there is a table showing the number of participants who completed the questionnaire at baseline, 4 months and at 12 months. At baseline, 2,444 participants completed the swallowing subscale, and this dropped to 1,861 at 4 months and 1,700 at 12 months. For the social eating subscale, 2,448 participants completed this at baseline, 1,834 at 4 months and 1,695 at 12 months. The loss of participants at 12 months on both subscales was therefore well above the 5% rate considered insignificant. No reasons were given in the study for the loss of participants over time. So for question 9 on the checklist, I would say no. Reasons to loss to follow-up were not described or explored. The checklist suggests that it is important that outcomes are assessed, otherwise selection bias may occur as a result of incomplete follow-up. We learned in question 9 that the authors report the attrition rates of participants at each time point for the questionnaires. In the next question, I will discuss statistical methods they use to handle this missing data. So for question 10 on the checklist, I would say yes, strategies to address incomplete follow-up were utilised. The checklist suggests when deciding whether statistical analysis was appropriate or not, to consider whether there was a more appropriate alternative statistical method that could have been used instead. The methods section should be detailed enough for readers to identify which statistics were used and how specific confounders were measured. On page 2, the authors explain that they were going to use Stata version 15 to perform chi-squared tests to compare the socio-demographic and clinical characteristics between the participants who completed the subscales and those who did not. Following this, the study described using a range of complex statistical tests and procedures. It used mixed effects linear multivariable regression, which allows it to analyse data with repeated measures from the same individuals over time. Importantly, it takes into consideration the fact that the measurements from the same person are likely to be correlated, i.e. the person is getting better or worse over time. They use bivariate associations to assess the correlation between the predictor variables collected at baseline, such as age, sex, ethnicity, etc., and the swallowing and social eating outcomes. If a variable was significant at 5% level, then it was included in the initial multivariable model. They used Wald tests, which simplify statistical models by identifying and removing variables that do not significantly contribute towards the prediction of the outcomes. Finally, they mention using Ak-Aike's information criterion and Bayesian information criterion, which are methods to compare statistical models to try and find the one that fits the data the best, but without overfitting the data. Lower numbers for the criterion suggest better fitting models. They found little difference between the models, so selected the least complex, a random intercept with structured covariance. Put simply, this model allows for each participant to have their own baseline swallowing and social eating difficulties. It acknowledges that there is likely to be some correlation between the data at baseline, 4 months and 12 months. It accepts that some data might be more strongly correlated than others, such as the data that is collected more closely in time, i.e. baseline compared to 4 months, compared to data collected further apart, i.e. baseline compared to 12 months. And finally, it needs fewer predicted variables to explain the data without overfitting. This potentially means the results are easier to interpret and more generalizable. So for question 11 on the checklist, I would say yes, appropriate statistical analysis was used. Having read the article and listened to me critically appraise it, how did you feel about it now? Did you agree with my ratings, or would you have rated anything differently? I'm now going to share my personal thoughts about the piece and offer suggestions about how I think it could be improved. In short, I think this study is excellent. The scope of this study is wide-ranging in terms of it being a national study where most patients who were diagnosed with head and neck cancer across the UK were eligible for participation during the recruitment period. This comprehensive recruitment strategy meant this ended up being one of the largest cohort studies not only in the UK but also the world. In terms of how its findings could be used in day-to-day speech and language therapy practice, the collection of such a wide range of variables at baseline and excellent statistical analysis meant the study produced extremely useful clinical information that therapists could use when giving advice and guidance about potential prognosis to patients before they undergo treatment. The general message is that yes, your swallowing will get worse during treatment, but by 12 months, most people will experience an improvement, not quite back to normal, but most likely better than during treatment. This message is simple, but hopefully reassuring. The more specific message is that the speech and language therapist can consider the individual's profile and suggest more specific prognostic outcomes for more vulnerable groups of patients, e.g. they might have a worse outcome if they are female, have oropharyngeal cancer, if they are undergoing combined treatments, if they live alone, etc. Some clinicians might have noticed these kinds of patterns in clinical practice already, but now they have robust evidence to back this up. In summary, it is a very practical, well-designed study. In terms of how the study could be improved, I will give a few examples. First, the authors acknowledge on page 7 that one of the study's weaknesses is that it only includes patient-reported outcomes which are weakly associated with dysphagia. An obvious improvement would be to include a swallowing assessment to complement the patient-reported outcomes and identify the presence and severity of dysphagia more objectively. How this could be done is more complex given the size and nature of the study. The baseline measurements were taken by a research nurse and included blood and tissue samples, so a swallowing screen could have been administered too. The 100 milliliter water swallow test has been validated in head and neck cancer patients by the lead author of this paper and could have been administered by a nurse. I have included a reference on the screen and will include a link in the description below to this paper. Unfortunately, data collection at 4 and 12 months was through questionnaire, so there would be no opportunity to re-administer the swallow test to check progress objectively. Other approaches that could have been considered would be for the nurse to look through the patient's clinical notes for any speech and language therapy assessment results close to the time points. Another possibility could be to use data from the food frequency questionnaire, which was administered as part of the larger study as a surrogate measure for how well participants are currently eating and swallowing, i.e., matching the reported food and drink being consumed to an IDSI level. In this study, the researchers used 3 items modified from the food frequency questionnaire: fruit, vegetables, and deep-fried food. So it is unlikely that the foods listed would cover the whole IDSI framework, so further items would have had to be included to make this workable. Second, the authors also acknowledged the potential selection biases involved from the original dataset, where only 61% of eligible participants provided complete data at baseline. They demonstrated that there was a difference between participants who completed and did not complete the baseline swallowing and social eating subscales, so I would have liked them to go further and report whether there was any differences between the participants who were included in all the time points and those that did not provide data at 4 and 12 months, to see whether there were any trends. This kind of information could potentially inform the design of future cohort studies if particular groups of participants were found to be more prone to dropping out. Researchers could provide more support to prevent attrition and improve the quality of data collected as a result. Finally, whilst I understand the decision to exclude the 951 patients with recurrent head and neck cancer, it would have been good if the authors had provided an explicit rationale to explain this decision. I wonder whether these patients could potentially have been included with the expectation that there might be high levels of attrition due to their presentation. Their inclusion would likely increase the severity of swallowing and social eating difficulties reported and better reflect the patients on the speech and language therapist caseload. If you found this video useful, give it a like and subscribe to receive notifications about similar videos in the future. You can also watch other examples of critical appraisal by clicking on the video on your screen now. If you've got any comments, questions, or have a request for other research you would like me to critically appraise in the future, then please let me know in the comments below or get in touch with me on Twitter. Otherwise, thanks for watching and take care.